I'm going to talk about the management of adults with Duchenne dystrophy, but there's a lot in this talk, so a lot to take on board and a lot to remember. And so just to let you know that we have produced some very short videos which have been translated by Little Steps into Hebrew, which you can download on YouTube. So think of this talk as just an introduction, and then you can, if you want to look up little bits afterwards, you can hear the videos online. And I'm going to have to talk a bit more quickly than I did in my last talk because I have a lot to get through. Again, these are my disclosures. So I'm sure you all are aware of the international standards of care, which have made a big improvement in the way we look after children and young people with Duchenne. And we now have more people coming through to our adult services, which is why transition is so important. And we have this very rapidly growing population now of adults with Duchenne. I've been working in this field since 1990, and I've seen huge changes. And in my current post, I started my clinic in 2011, and my number of patients has gone up from 20 to over 160. So this is going to grow very rapidly in this country. And things have changed so much. We see so much variety, as you heard earlier, in terms of the adults that we treat. So I would never have anticipated this in 1990, but 9% of the people who come to my service as an adult now are still walking. And many have good upper limb function, very few need non-invasive ventilation. Sorry? 9. And that's because of steroid treatment. But we also have a population of people who've never had steroids who are now getting older. So our oldest patient is now 40, and we have increasing frailty and complexity. So new medical issues are emerging. So in the United Kingdom, with the help of our charity, Muscular Dystrophy UK, we set up a multidisciplinary national network in 2015 of all 25 centres looking after adults with Duchenne. That's nearly 850 adults with Duchenne. And our goal was to improve and continue to improve and standardise that care across the country. And to that effect, we also developed our own care management guidelines. And we've also developed a national natural history database, which is very secure, so that we can start to look at the outcomes, we can look at geographic variation, we can see what's changing in the natural history, and also we can identify areas where more research is needed. So why did we need to develop our own care guidelines for adults? Because we have these very good standards of care that are already there. And our guidelines are not there to replace the standards of care that are already there, but they're to augment them, to supplement them. And the reason is because in adult care, as I've said earlier, the emphasis is on self-management and shared decision-making. And there needs to be very good coordination and communication between different specialists in the adult field, and I think that doesn't really happen at the moment, so it's something we have to work on. Also, the care emphasis is shifting from prevention or delaying to actually treatment of complications as they arise. And many of adult physicians that our patients now need to go and see have very little, if any, experience in Duchenne. So we're talking about emergency care doctors in the emergency room, gastroenterologists, endocrine specialists, surgeons, because you might need an operation for something, you know, appendicitis or something that just comes out of the blue, and that involves an anaesthetist as well. And also we're needing to involve urologists for treatment of kidney and bladder problems. And we have very little natural history data available, so we don't really know. There's so much we don't know. In fact, there's more we don't know than we do know, I would say. And we are learning all the time. And also, there have been very few clinical trials for adults with Duchenne, so all the trials are on younger patients. So we identified the need to develop this guideline. We invited patients, carers, families to an initial meeting to find out what their priorities were. And then we had a series of workshops where we looked at all the evidence that was available. We reached a consensus agreement, and we published individual workshop reports, and then finally one final report which was published, and this is the one where we have the short videos that are summaries. This report is just a beginning. It'll need to be updated as things improve over time. So this is the beginning of a journey that we're going on together. So our care guideline, this is open access, so anyone can download it. And it involves a number of different areas: respiratory medicine, anesthetics, cardiology, nutrition and bowel, renal, bone, endocrine, and also psychosocial participation and palliative care. And I shall briefly go through some of these topics, but also give you some of our own experience from our own center. So in our care guidelines, we suggest that respiratory care is monitored every 6 to 12 months, or sometimes more often. It depends on the individual needs. You can do home oximetry to measure oxygen levels at home, but it's quite hard to measure carbon dioxide levels at home, so we have to do that as an inpatient. But that may differ in different countries. And the treatment of choice is the non-invasive ventilation, and we need to provide 2 machines if people need it for more than 16 hours, and direct telephone access for replacement. We also provide advice on cough augmentation and cough assist, and also how to manage secretions with drug therapies. Anesthesia is a really important topic for our adult population. So if you are going to have an operation, the first and most important question to ask is it really necessary? Is this a minor procedure that can be done under local anesthetic, which is completely safe? Or is this a major operation that needs a general anesthetic or sedation? And sedation is equally important to consider. And we would say anyone who needs a general anesthetic or sedation, this should only be done in a center where there's expertise. So I work in a very big hospital trust. We have one anesthetist who anesthetizes all of our Duchenne patients, and she has built up expertise very quickly in a short period of time. We have a second anesthetist who assesses everybody a few weeks before the procedure to make sure that there are no unexpected things to be concerned about. And for young people who are not yet on non-invasive ventilation, we might need to start them on that several weeks before the procedure. We need to look very carefully at the heart function and the breathing function. There are certain anesthetics that need to be avoided. We need to think about hydrocortisone or steroid cover for the anesthetic procedure, but we also need to avoid prolonged fasting. Moving on to cardiology care, I told you this is a real whistle-stop tour, so there's a lot to get through. These are very similar to the standards of care that are already published with annual follow-up, but also in our adult population, we may need to add in additional drugs. So many of my patients also take a plerannone, which is a potassium-sparing diuretic. It reduces cardiac fibrosis. And some of our patients are also on a combination of another drug called sacubitril and valsartan, which is for people when their heart function is low. Ventilation, the ventilator is very good for your heart. So it's not just good for your lungs, it's good for your heart. But the other thing to remember is when you're on heart medication, this heart medication can lower your blood pressure, it can affect the perfusion to your kidneys. And I have here one message that I hope everybody will take home, which is this here, is drink more water. Because if you don't have enough fluid or you become dehydrated on these medications, or if it's very hot weather, it may affect your kidney function. We're going to talk about that. I have a research student called Alex, and she's just started doing a questionnaire on bladder symptoms. At the moment, the number of patients is quite small, but what is surprising is how many people with Duchenne experience bladder symptoms. And we have a lot of patients who have kidney stones and urinary tract infections. And the best thing to do is try and avoid this. And again, this is my message here, which is to drink more water. And I'm going to keep saying this through my talk because this is so important. I know many of the people I see drink very little because of problems going to the bathroom. But it can prevent so many other complications. And the most important complication we see is acute kidney injury. So if you get acutely dehydrated, the blood supply to the kidney is reduced, and that can affect kidney function, and it can make you very unwell. We've had it now, I think in our service, maybe about somewhere between 6 and 10 patients where we've had significant acute kidney injury. Fortunately, they've all recovered because we give them intravenous fluids. So rehydration can allow you to recover, provided you pick it up early. But it can cause anemia, and we have one patient who has to have erythropoietin very regularly now to keep his hemoglobin up. So again, if we can prevent this from happening, it's much better than treating the cause. And it probably is due to these heart medications in combination with dehydration. One of the biggest problems that I see in my practice is problems with the bowel and the gut. And again, Alex, my PhD student, has been doing a questionnaire. So far, she's studied 40 men with Duchenne, all adults. And you can see that 80% of the men we see have bowel symptoms. That's much more than I anticipated, and that's because we don't talk about it. And it's important to talk about it, and important to tell people what problems you're having, because if we don't know, we can't treat you. And what you can see, 80% have symptoms, but actually 80% are not getting treatment regularly. So we're not treating people as often as we should. And it's very hard to be weighed if you are in a wheelchair, so it's important that the clinics have wheelchair scales so that you can be weighed. We do this on our ward. And if people start to lose weight, I'm much more concerned about weight loss in our adult patients than in weight gain. Because weight loss, if it's too severe, can increase chest infections, makes it uncomfortable to sit. You've got no padding to sit on. And it can make people depressed, and it's very serious. And if people lose a lot of weight and become very thin, we have to be really careful when we introduce food. We have to do it quite slowly. So if you lose a lot of weight, if you came to our clinic, we would probably need to admit you to our ward for maybe 6 weeks before we even do a peg. And that's because we have to feed up very, very slowly. So again, a lot of these problems can be prevented by early management. So if we can see weight loss early, we can introduce dietary supplements, for example. So again, prevention is better than cure. We make sure all of our patients are seen by a speech and language therapist, because chewing and swallowing difficulties are also very common and not reported until you actually start to look for them. So what you need in your service is a friendly gastroenterologist. This is our gastroenterologist, Anton, who is always there for us, 24 hours a day. He's amazing. And I don't know what I would do without him. So I think a gastroenterologist is so important to your service for management of constipation. I think we don't know, what if we were to prevent constipation by regular laxatives, might we prevent some of the complications that we see? We don't know what effect steroids have. Do steroids prevent these complications from happening? This is research we need to know, and we need to ask those questions. And we do know that the gut has a much slower transit time in Duchenne. So we would, so Anton will use a drug called Propulsid or Cisapride, but we have to monitor the ECG when people are on this drug. And also we try a FODMAP diet, so avoiding the foods that cause a lot of gas can sometimes be helpful, things like onions and peppers. And for people who have a PEG or who have bowel distension, you can do some venting through the tube, either through the bottom end or both ends, or top end. And the other thing that Anton does is he looks for bacterial overgrowth with a breath test, because that can cause abdominal distension, and if he finds that, he can treat that with antibiotics. But I think it's really important to really prevent constipation, and this is something, when I talk to people in my clinic, they get really embarrassed about it, but honestly, it's my bread and butter, it's Anton's bread and butter, and it's really important we talk about it and try and deal with it. And again, what helps to prevent constipation is water, so drinking plenty of water and not getting dehydrated. Because otherwise we can see a lot of acute problems, and they can be quite serious, and we have to liaise with local hospitals to try and manage these problems that we see. So here's a question that I get asked lots of times, and it's a debate we've had in the British Myology Society: should adults with Duchenne be treated with steroids? And it's a difficult one. Certainly I would not start an adult on steroids, but if an adult comes to me and they're already on steroids, then we have to have a good reason for stopping. And that good reason for stopping would be if they're not making any difference, or if the person wants to stop. Otherwise, we carry on. We need to think about having an emergency plan with hydrocortisone for people who are on steroids, so they have a supply at home. And also we need to think about other endocrine problems, so delay in puberty, treatment with testosterone, and also when you have very little muscle, you don't store carbohydrates, you don't store glycogen in your muscle, so you may be at risk of glucose intolerance and other complications that are metabolic. And also we need to think about fractures and bone protection. So looking at steroids, I'm sure you all know this already, but they do make a difference when it comes to slowing down the loss of walking, so in younger boys, so we know that's a benefit. But we also know that they delay the decline in breathing function, so they preserve the strength of the respiratory muscles. And also if you look at the upper limb muscles, this is steroid treated and this is non-steroid treated. It again preserves upper limb muscle strength, so it keeps you stronger for longer. When we look at our population of patients, we find that about half of them have had to stop steroids before they come to us because of the side effects. So if the side effects outweigh the benefits, that's a reason to stop. But many of our patients have been on steroids for more than 10 years, which is a long time, and it's a high dose of steroids. I better hurry because I'm running out of time. And this is just to show that the breathing function is better in our steroid-treated group, as is the heart function. And this is just to show you that our steroid-treated group, fewer of the patients need ventilation, fewer need scoliosis surgery, and fewer need feeding tubes. All of our patients are on heart medication as per standards of care. One of the side effects of steroids is cataracts, so we've had patients who've needed cataract surgery, and also fractures, but I think generally our patients are better when they're on steroids. And I'm going to whiz through very quickly that we have to have guidelines in place for managing metabolic disturbances, particularly acidosis with acute dehydration. And actually, our diabetic patients, we have more who are not on steroids than are on steroids. So it's the opposite to what people expect. There are protocols for bone protection, and as I said, for adrenal insufficiency. And finally, participation. We heard a lot about that this morning. That's very important in the way we manage our adult patients. And we need to make sure they have a full range of therapy services. But also what's very important is every service should have a psychologist and a palliative care physician embedded in their service so that we can support with symptom relief. I'm almost done. And also we need to support families as well, and carers as well as the patient. And the last slide is to say a huge thank you to the Duchenne Research Fund, who have funded in the UK two psychiatrists, one in our centre, one in Newcastle, and 2 psychologists. who are going to be looking more at the psychosocial impact and the drug treatment for some of the psychiatric features that we see in our service. So I'm sorry I've gone over time. I'm going to stop there. But I just want to emphasize how complex the healthcare needs are for the adult population. They're changing, they're evolving, we're learning as we go along. For adults who are here, please remember to drink more water. That's going to be all I'm going to say. And thank you to our team.